The Trust's End of Life and Palliative Care team are at the Academy, Great Western Hospital, this evening, and they're going to be leading a talk to encourage open conversations about death and planning for the end of life. Welcome, Lorraine Hart, End of Life Nurse Specialist. Lorraine, why was it important to have this evening?
Well, this week is Dying Matters Week, and it's where we encourage people to have the conversations about death and to be open about it, make it everyday conversation. We find that often people leave it too late to have the conversations. If you have them earlier, it can be a bit more hypothetical and it's easier to have them. I think it's help on both parts. So for the patient, they can feel they're getting their wishes across. They might have lots of things they want to get across and find it hard to talk to. And for the person who's left behind, it often they can grant those wishes and they know what they want.
Is it something that helps keep couples or families together if they can talk about it openly? Because not everyone does, do they?
Absolutely not. And we really find that people don't want to talk about it because they find it's frightening, it's upsetting, it's often seen as more of a conversation. I don't know if it necessarily keeps people together, but I definitely think that at the end of life, if people's wishes are known, that it makes it a lot easier and for both parts, both patient and family who are left behind, because they feel they have given the patient their wishes.
It must be difficult if you don't know someone's wishes and you are fast approaching end-of-life care to bring up a conversation at the last minute.
It can be, and everyone's different, and some people can talk about it quite easily and some people don't like to talk about it at all, and we often leave it too late. And if a person loses capacity, we don't know what's around the corner, none of us do, then if we leave it too late, we don't have that chance to have that conversation. So it's always better to have it early and make it just part of everyday conversation.
Would you advise someone to talk about things in a certain order or plan a certain time to have this conversation?
Absolutely not. I think every one of us is different. If you want to have that planned time, then it's always good to say, well, actually, can I talk to you about my wishes on Tuesday? Other people like to just drop it into conversation and have a conversation little and often. Other people like a long conversation and then pack it away and don't talk about it again. There's no right or wrong, and we're all completely different, so it's whatever's right for you.
Any ideas on a conversation starter to bring this up if someone is ill, or even if you're fit and well, just to begin the conversation?
I suppose you could say things about if you're watching something on television, for example, if someone is dying, or if you're listening to a song on a radio, you might like to say, "Ooh, I'd like that song played at my funeral." Or if you're watching something on television with some drama or something, saying, "If that happened to me, I wouldn't like such and such a treatment," and just start it that way. And what we're trying to do as well is get people to pick up on cues. So if my mum did that, for example, it's a way for me to open a conversation with her, so it works both ways.
So if someone has had a conversation and they've said, I would like this treatment or I wouldn't like that procedure, how do you document it? How would someone be expected to remember this conversation? Should they be writing it down?
Absolutely. It's always good to write things down. We have these booklets called advanced care plans. We have them in the hospital. The GP surgeries should have them. And also there's a site on the internet called Compassion and Care, and there's lots of leaflets on there for people. They can write down their wishes. There's also an advanced care directive, which is something that if people don't want particular treatments, something happens to them, and they're also on that website. And also there's a document called the Lasting Power of Attorney, and that's for health and welfare, and that's if you lose capacity, that you can nominate a donor who can make decisions for you. And unless you do that, then really the decision is up to the medical team. So it's always a really good bit of advice that you can nominate a lasting power of attorney, and you do have to have that registered with the Office of National Guardian. But, yeah.
If someone wants to make these their wishes known, is there a certain place they should keep the document or store it? Because you never know when you're going to be ill. And
absolutely. You can always keep, the best place, if you can, is to keep it on you. But let your family know. Give your family a document. Go to your GP, let your GP know that you've made a document. You can also get little cards on the compassionate care to say that you have got a care plan in place. There's lots of different ways, but always write it down and chat and let your family know.
The next nurse I met was Ruth Alderton, and she's a team leader with the palliative care team. And I asked her about palliative care. What is it to her?
Palliative care, I think, to me, is helping people make the most of the time they have left, however long that time might be. So our role is, every patient we meet is very different. We could be supporting them for their last year of life, or it could be in their last few days or hours of life. For some patients, it can be the basics of making sure that they're comfortable and making sure that they've got the right pain relief and the right medication. For other patients, we're able to sort of walk alongside them a bit more and help them fulfil certain wishes, whatever they might be. So it's very, very varied.
So even though the patient's state of health would mean that they're not going to be entirely well, you can help them feel more gathered in and whole as they spend the last time that they have.
Yeah, definitely. Yeah, our role is very much about holistic care, so providing not just the medical care but the psychological and emotional support, support for the family, for their loved ones who are affected by the patient's disease. And it can be support in all different ways. So there's support from the family support team at the hospice, there's the open programme, there's all sorts of different support out there depending on what the individual need is.
Is this, the palliative care team, is this something that you would offer support for no matter what the condition would be that brings someone to need palliative care?
Yeah, so we help people, whatever their condition is if it's been shown to be a terminal diagnosis. So it could be cancer, it could be heart failure, it could be chronic breathing difficulties. So for anyone who the doctors have felt that they are approaching their last sort of 6-12 months of life. Yeah.
What kind of thing helps people in those situations?
I think that the largest part of our role is probably just getting to know people and finding out what support they need, because everyone is slightly different. For some people it will be a complete shock that this is happening to them and they'll need real help adjusting to it. For other people, they've known for a long time that they're unwell and they've come to terms with the fact that they're dying, and they're much more accepting, but there are particular things that they'd need help with. So it varies hugely, and I think it's a great honour that we have to be able to do this role and be able to get to know people and find out how we can help them.
Do people ask you what's it going to be like at the end?
Yeah, sometimes that does come up. Sometimes people want to talk about it. Other times people don't want to know, and that's absolutely fine. Our role is to walk alongside people with whatever they want. So if they do want to know, then we would try and talk them through maybe what to expect. Obviously none of us have a crystal ball, so we don't know exactly, but we can say from our experiences what's likely to happen. Other people don't want to think about the end at all, and that's their right as well, so we support them in whatever way we can.
My next guest is Dr. Joseph Hawkins, who's a palliative care consultant at the Great Western Hospital. Now, you're a palliative care consultant, but that's not on a ward, is it? You could be anywhere.
Well, my job is working in conjunction with the palliative care nurses with whom we've already heard. And so many of the aspects of our jobs overlap. I suppose the medical aspect of my job really comes from working as a specialist with all the different teams within the hospital, and so I reach into all of the adult care wards, whether it's surgery or general medical, or in fact any combination that you can think of, really. And we're referred to by all different groups, so the doctors, the nurses, the patients themselves can self-refer to us as specialists, and we'll come and see them. And I think, as you've picked up as a theme, it's not necessarily about how a person dies, but it's about how a person lives, and trying to achieve that life with as much quality and happiness as possible. I think the hardest thing for many people is that loss of control and that uncertainty about the future. I often talk to people about the way in which we all live, not quite in the present, but a little bit in the past and a little bit in the future. I use the analogy of eating one's own dinner. And when it comes to eating dinner, how many of us sit in the moment enjoying our dinner, and how many of us are thinking about the next thing that we've got on our little list of to-do jobs?
Yeah.
And that's a habit that we get into as adults, and it doesn't ever really leave us simply because we've had a life-changing diagnosis. And so when we're faced with something that changes the pattern with which we've set our life to, we suddenly find ourselves not quite on the track that we thought we were going to be on. And that's not only scary, but it also leaves us with an existential fear of perhaps facing some of those concerns, because if we do face them, are there answers? Although it's not particularly pleasant to think about, at some point those thoughts are inevitably going to come back to us. And when it comes to this living a little bit in the past, a little bit in the future that we all do, then these thoughts will only multiply over time if they're not addressed. And that's, I suppose, where I come in and where our services come in. And that, too, is where often GPs and other healthcare professionals can help to support people, because it's starting to manage that uncertainty, to recognise the known unknowns, to allow people to express their fears and their worries and to listen to them, and sometimes to recognise that there may not be an answer to everything that we worry about, but to listen to them is important, and part of learning to adjust to a changing situation that we've not had the opportunity to prepare for at any other time in our life.
Our guest today, Helen.
Hello.
Hello. Now, Helen, you're an end-of-life specialist nurse.
That's right.
And you have, well, I when I first saw you do this, it really brought tears to my eyes. But you have a bag with you. Would you care to tell us about your bag?
Okay, so just following on from what you've heard already today, it's really important to think about what's important to you. So you can write this down and keep it with you. I have a bag just to show what's important to me. So in my bag I have a number of items. I have a photograph of my children. I have 3 wonderful boys, and they're very important to me. So should I be facing my death, or my life is coming to an end, then I would want my children to be involved in any decisions making, and I would want them to be with me wherever possible. So I wouldn't want visiting to be restricted.
So everything in your bag is a meaningful thing. This isn't any old bag, is it?
No, absolutely. Everything has a big meaning to me. So, I might not just be given a diagnosis that gives me months or years to live. I could suddenly have some sort of catastrophic event. I could suffer a stroke or have a terrible head injury. So should that happen, then these things are important to me. If I can't share them or explain them, then I want people to know that they absolutely, to make me happy, include these in my care. Also in my bag, I have a pillowcase. I like to have a really cool pillow to lie on. So if I, in the middle of the night, might be a bit restless or upset, then try turning my pillow over. It might just be that I want a cool side of my pillow under my head. I have my glasses case because I wear glasses all the time. I have to have my glasses on. So obviously, if you want me to interact, you want me to see anything, then you're going to need to put my glasses on, because otherwise I won't be able to see what you're showing me. You might not get the responses back that you anticipate if I can't see.
But this is all gold dust to the people. This is that information that we talked about planning things. This is the thing that the person, your visitor, could do it, the
Absolutely.
nurse there with you could do it, and that would enable them to get close to you if you're in a position where otherwise they might think, well, what do I say to this lady? How do I help this lady?
Yes, absolutely. In my bag I have a coconut filled with bird food. It's a rather odd thing to have in my bag, but I love looking outside and seeing the birds, and so if you could nurse me beside a window on the ground floor with a bird feeder outside so I could watch the birds, obviously with my glasses on, then I think I might stay calm and be happy for a few hours. I have some orange nail polish in my bag. I can't wear nail polish to work as a nurse, but I do like to have my toenails painted, and I love orange shoes, hence the colour orange. So maybe if you need me to go somewhere, put on some orange shoes. I'd feel very special in my orange shoes. I have a CD in my bag. It doesn't have to be any particular CD, but I love listening to music. I like having background music going all the time. So when I'm at home, the radio is on all the time. So again, just something in the background to keep me quiet and entertained. I have a book. I love reading. I may not be able to read, but maybe in this day and age I could listen to a podcast, or I could listen to...
You could listen to a podcast of this.
Absolutely,
later.
I could listen to a podcast of this. Or I could listen to a play or something on the radio. So again, that's important to me. And finally, in my bag, I have a medal. I like to run. I'm quite active. And so just remember that this person that's in front of you, who looks maybe very old and wizened, was actually interested in sport and did have a life before the diagnosis. So just remember that I am more than just what you see in front of me.